Good afternoon, everybody. Thank you very much for joining us this afternoon. Hopefully we can go over some things that might be of interest to you and answer some questions that you might have. And let's get started. So numbness and tingling in the upper extremity is a relatively common thing. It's probably one of the most common things that I see in the office. There are a number of different causes of numbness and tingling in the upper extremity. We're going to hit on some of the more popular ones today, highlighted in the white writing on this list. There are a lot of myths about what causes numbness and tingling in the upper extremity, and we'll go over some of those things as well. And the list is even longer than what's on this slide. There are some more rare things that something called pronator syndrome that, again, these things are things that come up infrequently, and we're going to hit on some of the more popular things today. So carpal tunnel syndrome is the most common nerve compression syndrome in the upper extremity, and it's appropriately named. It actually is a tunnel. So if you look at the picture on the right, this little space, this little tunnel is the area of interest. Now this is a cartoon of the bones in your wrist, and you have 8 small little carpal bones in your wrist. So that's why we get the name carpal tunnel, because these little carpal bones form the floor of that carpal tunnel. And there's a ligament that connects these bones, which is a ligament in name only, in that it's a piece of connective tissue that's connecting bones. So that's where it gets its name. It's a bunch of carpal bones making the floor of the tunnel connected by a ligament. By the way, this picture, if you sort of looked at your hand like this and sort of took off the fingers and took off the forearm bones, that's what you'd be seeing. You'd be looking straight through that tunnel. So a couple of quick notes about carpal tunnel syndrome. The nerve that's affected in carpal tunnel syndrome is known as the median nerve. It does affect women a little bit more frequently than men. There are some known causes. There are some congenital anomalies that sometimes can predispose folks to this. If you use a jackhammer every day, that could potentially predispose you to this condition. Very frequently, we see women who are pregnant, and all the fluid retention that occurs during pregnancy can cause this, usually temporarily. Often it resolves after pregnancy. If you have a mass, a cyst, or a tumor that's compressing the nerve within the tunnel, that can be a source. Trauma is a little bit controversial. There are some conditions where trauma can cause increased swelling or increased thickening of the tendons around the nerve that travel through that tunnel. Sometimes when folks have a bad wrist fracture, that can cause compression of the nerve because the bones have sort of shifted the position. And so sometimes an acute carpal tunnel syndrome can occur in that setting. And there are some associated conditions where it's just a little bit more common as well. Like I said, there are some myths about this, and somewhere along the lines when computers became more and more common, more popular to be used, folks thought that computer use was the main source, and I hear it all the time in the office. Well, I use a computer a lot, so it's understandable that I get carpal tunnel, but actually there is no known direct correlation between computer use and carpal tunnel syndrome. So just some more pictures here. So again, it is a tunnel. This is another picture that just sort of shows how this works, where these little carpal bones create the floor of the tunnel, and there's that ligament that is the roof of the tunnel. There are also tendons that run with that nerve within the tunnel, which all of these things can sort of narrow the space for that nerve. And nerves don't like to live in a narrow space. They like to have plenty of space. And when the space becomes narrowed, then you start to develop some of the symptoms that are listed on this slide. There's no one particular symptom with carpal tunnel syndrome. It can often be a spectrum of different things. Pain is often something that I hear about, but it doesn't always have to be painful. Weakness or clumsiness, folks will often tell me, my coffee cup dropped out of my hand. I didn't even realize what was happening. Or I dropped the pen the other day. I didn't realize. Numbness is probably the most common thing that we see with carpal tunnel syndrome. And if you focus on the green shading on the hand, that is the distribution of that median nerve. And so the areas that are labeled green, that's typically where people will feel carpal tunnel syndrome. Now, it's interesting. So because that's a large portion of the hand, many folks will come in and say, well, it's my whole hand that's affected. Well, if there's only 1.5 fingers that are not affected, then I can understand where it sort of feels like the whole hand is affected. But it's typically just the thumb, index, long finger, and then the thumb side of the ring finger as well. Things that I hear also, it's worse at night. We do tend to retain a little water at night. Folks will say all the time, oh, I wake up in the middle of the night and I have to hang my hand off the side of the bed, or I shake it and it starts to feel better. Back when newspapers were a little bit more common, folks would talk about reading a newspaper causing trouble driving, having the hands on the steering wheel, often with the wrist in a bent position, brushing your hair. These are all common activities that sort of exacerbate the symptoms. So there's different ways that we diagnose carpal tunnel syndrome. Largely, it's a clinical diagnosis, meaning I listen to your symptoms and I do a physical exam. And if those things go along with carpal tunnel syndrome, that's usually enough to make the diagnosis. Most of the time, we get a special kind of test called a nerve study. There's actually two different studies. One is a nerve conduction study, and the other one is called an EMG, which the nerve conduction study just tells us if the nerve signal is being conducted at an appropriate speed. If it's faster before the carpal tunnel and slower after, then we know that there's some compression of that conduction. The EMG portion of that test looks to see if any of the muscles that the nerve innervates are affected, and that usually is indicative of a more severe compression. Another diagnostic test that can be very helpful, it's a little less common, but doing a diagnostic ultrasound, where often the nerve will have some swelling around on either side of the carpal tunnel, where you see that there's compression at the level of the carpal tunnel, but the nerve will swell on either end of the tunnel, on either end of the ligament. So in terms of treatment, the initial treatment, and treatment if it's not severe compression, is a brace sort of like the one that you see on the in the picture on this slide. That's just an example. There's no one brace that works. It's basically the goal of the bracing is to keep the wrist in a straight position. If your wrist is bent like this or bent like this, there's more compression of that nerve as it travels from the forearm into the hand. When we sleep at night, most of us will kind of curl up like this or like this when we sleep. And so that's an extended period of time where that nerve is in a compressed position. Nerves don't like to be compressed for long periods of time. On the flip side, they like to be not compressed for long periods of time. So if you get to sleep for 8 hours a night and your wrist is in a nice functional position without any compression on the nerve, then the nerve likes that. And during the day, it'll pay you back. It'll be nice to you during the day. If you keep it in a very bent position for 8 hours throughout the night, then during the day it's gonna be angry with you. Another treatment option is to do a steroid injection. Now, I like steroid injections a lot for certain conditions. It's not my favorite. Carpal tunnel syndrome is not my favorite condition to use steroid injections for a couple of reasons. Number one, it is often temporary. So even if it is helpful, the relief that you feel is often temporary, and the symptoms often do come back. There are some risks of putting the injection, the medicine, the needle near a nerve. Nerves don't like to be stuck with sharp objects for sure. Obviously, there's safe ways of doing that doesn't happen, but there's always risks of involving injections. It doesn't work at all typically for severe cases. Steroids are typically anti-inflammatory, so if inflammation is part of the source of the compression, then it can be helpful. But in the absence of a significant amount of inflammation, if it's just a mechanical compression, the cortisone typically isn't develop worse symptoms throughout the course of this. But things that we see often, if you're above 50 years old, if your symptoms have been going on for close to a year, if your numbness is more constant, if you have associated trigger fingers, which is a tendon problem where tendons get stuck going through little tunnels in the fingers, some of these are so things that sort of predict that you're probably going to end up needing a surgery for the problem. And of course, if your nerve studies show severe compression, then you're pretty much immediately a candidate to do the surgical decompression. If your nerve studies show severe changes, then it's unlikely that any non-surgical treatments are going to make this better. And we also want to make sure that we're not going to develop any kind of permanent injuries to the nerve. You know, if there's pronounced sensory loss, if it's been going on for a pretty long time, and if it's not relieved, sometimes the symptoms will get better and worse. As I mentioned before, often they're worse at night. If it's just the same, it's constant, it doesn't go away with anything, then you know, the surgery is typically going to be the best answer. So there's different ways to do the surgery. You can do it through a small incision that usually is about you know, from here to here in the hand, or where it's just open and you're visualizing everything, or you can do it through smaller incisions and put a camera in to look and see. There are a couple of differences. It's obviously a smaller incision with the camera, or usually it's two smaller incisions. There's a couple different systems. In the literature, the only functional difference was that there was a slightly earlier return to work with the endoscopic or the camera versus the open incision. I typically do them open because I just like the visualization of being able to see a nerve as well as you possibly can. Every once in a while, I run into some abnormal branches of the nerve that I'd get concerned that I wouldn't be able to see if I just put the camera in. So that also makes me want to do it open. And people tend to recover pretty quickly and not have much difficulty getting back to activities, even with the open approach. That being said, the endoscopic approach is 100% fully accepted, and people do fantastically with that as well. It's usually more you know, surgeon preference. And you know, typically it's the cure. You know, the surgery is the cure. It makes it go away. It goes away forever. Typically, there is a small risk of it recurring at some point, but it's a very small risk, and I very infrequently see anyone who comes back with a recurrent carpal tunnel syndrome. So that's carpal tunnel syndrome in a bit of a nutshell. Hope that was interesting. We're going to move on to the second most common nerve compression syndrome in the upper extremity, which is called cubital tunnel syndrome. And again, you know, another small tunnel. This one occurs at the elbow instead of the wrist. And this one involves a nerve called the ulnar nerve rather than the median nerve. So when I showed you that hand before that had the green shading on the thumb, index, long finger, and this side of the ring finger, that was the median nerve. So you might say, well, what does the other non-green portions? That's the ulnar nerve. And the ulnar nerve can be compressed in the wrist. It does go through, it's a canal. We call it Guillen's canal instead of a tunnel over there. So instead of being another tunnel over here, it's a canal. But it's much less frequently compressed around the wrist and the hand. The ulnar nerve often can get compressed around the elbow. So just a couple of things about the anatomy here, and I'll show you some pictures later also that describe this as well. In this little cartoon, you can see the nerve comes around the back portion of the humerus and then follows through into the forearm. One of my mentors in my training used to talk to patients and say, well, if the Celestial Design Committee could do it all over again, they would move that nerve from the bottom part of the elbow to the top part of the elbow. And part of that reason is, so again, this picture down here has a little line drawn where the nerve is, and that circle is where sort of that protrusion called the medial epicondyle of the humerus is. So if you imagine, if I took a string and I taped it to this person's forearm over here, and I ran it down the back of the elbow, around the pointy part of the elbow here called the olecranon, and I taped it to the back of the arm there. And I taped it in sort of a nice sort of, so that it was touching the skin. And then I told this person, go ahead and bend your elbow up, right? You can imagine that string will feel tight as it goes around the elbow. And oftentimes that can happen with that ulnar nerve. So people will sometimes get pain around the elbow with some flexion. Again, similarly to the, we mentioned with the carpal tunnel syndrome in terms of keeping our wrist in a flexed position. We often will keep our elbows in a flexed position when we sleep at night. So often it can get worse at night. And that ulnar nerve does affect sensation in the hand, but it can also affect some of the strength in the hand as well, especially pinch, and grip and pinch, I should say. So again, hopefully this comes across okay, but you can see this is sort of a depiction of what I was describing with the string, where as that nerve goes around the back portion of the elbow, it can get pinched in that tunnel between the bones. This white portion here is one of the ligaments that holds that nerve in place within that cubital tunnel. And so there's, again, different treatment options, and you'll sort of note a theme here. Nighttime extension splinting is an option, and I'll show you a picture of an option. There's many different ways to do that. You know, avoiding flexing your elbow, you know, that's the kind of thing where during the day, most of us don't walk around like this, right? So during the day, we often, you know, you keep your elbow in a more functional position, but at nighttime, we do tend to curl up with our elbows flexed greater than 90 degrees. And that's why we usually focus on nighttime splinting. Leaning on the elbow. So if you lean on your elbow, I'm sure anybody watching has at some point had their elbow slip when they were leaning on it, and they get that funny bone, you know, discomfort, that shooting pain going down their forearm. That's the ulnar nerve. That's the funny bone nerve. And so leaning on the elbow, typically we more often will lean on the inside part of our elbow, right where that nerve is. So that actually is also putting some compression on the nerve as well, and that could make the symptoms a little bit worse. And of course, there are surgeries for this as well, and similar to the carpal tunnel, where there's some surgeon preference in terms of what they think is the best option. You can do what's called an in situ release, which is basically where you just cut that ligament to alleviate the pressure off the nerve. That does leave the nerve still in the position along the back of the elbow. And so that's not my favorite operation for this particular problem as well. Again, it's a perfectly acceptable option. The literature does support that. The outcomes are similar between that in situ compression versus what's called a transposition. And that's what the transposition is, what's depicted in this lower picture here, where you take that nerve away from the bottom part of the elbow and you move it up to the top part. Again, with any nerve surgery, as I said before, the goal is to halt progression. Oftentimes when the symptoms and the nerve studies show that the compression is not terribly significant, it's not terribly severe, then the symptoms often do get reversed and people feel so significantly better. The pain goes away, the numbness goes away. But the primary goal is to halt progression. And sometimes when the compression has been going on for long enough, there can be some permanent changes. I'm sorry, I thought I had a picture of a splint, but there are different types of splinting options in terms of the nighttime splinting. It could be as easy as taking a hand towel or a dish towel and putting it along the front of your elbow and then wrapping that up with an ace bandage, just so that it prevents you from flexing that elbow up too much.
Sorry about that, Dr. Crivello. We just lost internet connection for a second, but I think you're back and good to go.
Okay, great. All right, so I'm not sure where it got cut off, but what I was saying is that there is a lot of overlap between the neck and the upper extremity, because the neck is sort of command central for the upper extremity. This is just a list of various things that can cause compression of the nerve roots that are coming off of the neck or of the spinal cord, which obviously is running behind the vertebral bodies in the neck. And I'll show you a side view. These pictures are always funny. They look like little aliens to me when, if they're out of context. But you have the vertebral bodies, which are the tan portions here, and then in between those vertebral bodies, the bones, are these little intervertebral discs. Again, the spinal cord runs right behind these vertebral bodies, and the nerve roots are these yellow these yellow strings coming out through here, which join up to form those peripheral nerves that we were discussing in the previous conditions. So it's going to advance to the side view, because oftentimes we look at these side views, you can see a little bit more of the anatomy. Again, the vertebral bodies have these little intervertebral discs between them, and you have these nerve roots that are coming out in between as well. So there's joints within the spine, both in your neck and your lower back. Again, focusing here on the neck, because that's what controls the upper extremity. And there's a number of different things that can cause either irritation or compression. Many people, if you were to do an MRI of every person that you look at over the age of, let's say, 50 years old, there's probably going to be some evidence of a disc herniation, or the discs are not going to look pristine at some point in life. The question is whether or not those herniated discs actually cause significant compression or cause any trouble. But it's a popular thing that you hear about all the time, that, folks that talk about having herniated discs in their neck or their back. Some of them are symptomatic and require treatment, but there are other structures that can also narrow those spaces for the nerve roots, or cause irritation to those nerve roots, which also can be a source of numbness and tingling in the fingers. Again, this is a long list. It's not an exhaustive list, but there are, I left it as a sort of a long list just to show that there are a number of different conditions that can affect the neck, and that's why it's such a common thing as well. In addition, there are, you can have something called a double crush. So you can have some compression up by your neck and have compression at your carpal tunnel or your cubital tunnel, in which case that can sort of be additive, where you have nerves being compressed in multiple places. So when I see folks for upper extremity numbness and tingling, that's always on my list of things that I need to make sure to rule out, before we move on to the peripheral nerve compressions, like a carpal tunnel or a cubital tunnel syndrome. Physical therapy is the mainstay of treatment. It's an initial treatment. It often is curative for many of the issues that affect the neck. Anti-inflammatory medications can also be helpful, because often there are inflammatory changes or arthritic changes within the neck that extra inflammation, the swelling as a result of that arthritis and inflammation, can be sources of compression. So anti-inflammatory medications can often be helpful. And if the combination of the physical therapy or anti-inflammatory medications aren't helpful, then that's when I start to have you see a couple of my partners, either my physiatry partners, interventional pain partners, who can do some injections under X-ray guidance, or the surgeon, the spine surgeons, who can make your neck look like these X-rays, where you often will fuse those bones together. So I mentioned that just to be complete, but that's beyond the scope of what I do as an upper extremity specialist. But it is important to include that cervical radiculopathy, which is basically compression of the nerves or the spinal cord around your neck. That is one of the potential sources of numbness in the upper extremity. So I think we'll move on to any questions now. All right, so I'll just take them in order here. So first question is it okay to use the brace every night, even if you're not having symptoms? So absolutely, it's okay. There's very little downside to using a brace at night when you sleep. If you tolerate it, if it doesn't keep you awake at night, if you don't have any problems, there's almost no downside to using a brace at night when you sleep. And it often could be preventative too. So if, let's say you had a lot of symptoms, you were using the brace and it got better, well, you can have a trial of not using the brace and see if it makes sure it stays okay and it's not getting worse. But if you say, well, I don't want this to come back, so I'm going to continue to use the brace even if my symptoms aren't there, that's totally fine too. What I don't recommend is using the brace full-time during the day. Over time, you can get stiffness in your wrist, and we would never advocate immobilizing any joints, 100% of the time, just because that can be an issue. But again, at night, that's totally okay. Next question, where do you do these surgeries? Good question. So the nice thing about these surgeries, and actually something I probably could have mentioned before, is that these can the carpal tunnel release can be done under either just local anesthesia, where you're wide awake and we just numb you up and do the surgery, or you can also have a little bit of sedation with that as well. It's sort of like the kind of sedation you would have for like a colonoscopy or your wisdom teeth or something like that. You don't have to be completely under with a tube or anything like that. Just a little sedation. Typically, the ulnar nerve surgery, we do it with more general anesthesia or a nerve block, and sedation. But these can be done in a surgical center because they're outpatient surgeries. You go home the same day. We have a fantastic surgical center over in Lawrenceville. Actually, Newsweek just named it the #1 surgery center in New Jersey. And I think it's actually in the top 15 or so in the country. It's a wonderful place, and that's where I do the majority of my surgeries also. Next question, forearm pain and weakness and shoulder pain. So shoulder pain could be about 5 different of these webinars by itself. So shoulder pain, I think we'll sort of exclude. Forearm pain and weakness, a lot of the things that we talked about today, even if I didn't specifically point out that nerve compression syndromes in the upper extremity can cause pain and weakness, there are other conditions. There are tendinopathies, meaning issues that involve the tendons itself. Like tennis elbow is the most common type of tendinopathy that'll cause forearm pain and weakness. That it's a little bit of it can often be a very different category when we're talking about some of those things. The numbness and tingling in the forearm. Again, what I was trying to say in the first slide, there's not like a clear cut. It's only these symptoms, and if you don't have these specific symptoms, then it's not carpal tunnel syndrome, cubital tunnel syndrome. So there's a spectrum of that people will feel, and people are these symptoms are often subjective. So how I sort of feel my carpal tunnel syndrome may be different than how whoever asked that question may be feeling it. But again, there's a little bit of a broader list of things that can just cause general forearm pain and weakness. Next question, good one here. Any connection between cell phone use, texting, and/or carpal tunnel or other conditions? So there's never been any study that has shown a direct correlation between cell phone use, like for example, texting, and carpal tunnel or other conditions. Though there's been no study that has shown any direct evidence to computer use. There was a very small association between carpal tunnel syndrome and specifically using a mouse for greater than 30 hours a week. So I guess like if you're like a graphic designer or some, not like somebody who's like, you're typing for 10 minutes, then you use your mouse to click to the next thing, or it's actually like using the mouse itself for 30 hours a week. There was some small association, but it wasn't even a direct connection. Okay, next question. These are great questions, by the way. Did not mention tingling with carpal tunnel, but did with neck issues. Tingling associated with carpal tunnel. Thank you. One of the things you learn after you've been in practice for a while, how some people will come in and describe their symptoms, or even the words that they use for symptoms they could be having the same exact symptoms and have the same exact diagnosis, but they'll describe it completely different than the next person I see. And so anything that is nerve related, that involves a nerve compression, whether it's with the carpal tunnel, the cubital tunnel, neck compression, elsewhere in the lower extremities, numbness and tingling go along with that. Typically when my understanding and the way I think about numbness is sort of that you lose sensation, it doesn't feel the same, if you touch something, it doesn't feel the same. And there are deeper definitions that we could make with in terms of numbness. And tingling is sort of that buzzy feeling, that tingling, like you sit in your leg funny, and when you wake up and you get that tingling feeling. So they're all nerve related, and so any kind of nerve compression can elicit those symptoms. And like I said, some people feel pain as their worst symptom. Some people feel numbness as their worst symptom. It's a spectrum. What is next? Stenosis. So when we talk about stenosis in anywhere in the spine, whether it's in the neck or the lower back, typically what we're talking about is, well, there's two different places where you can really describe stenosis. So the spinal canal, where the spinal cord goes through the spinal canal, that can get narrowed from a number of different things. There's congenital stenosis, where people are just born with a more narrow canal. If those discs that I pointed out start to push back towards the canal, that can cause stenosis or narrowing of that space. Sometimes when the joints around the spine get arthritic, they can add bone spurs and things like that can narrow that space. The other place where we talk about stenosis anywhere in the spine is where the nerve roots come out. So those little spaces where the nerve roots come out are called the foramen. So we call that foraminal stenosis. So the symptoms might be slightly different if the spinal cord is affected than if just an individual nerve root is affected. Next question, trigger finger. So I'm happy to discuss trigger finger. It technically would not fall under the category of a nerve compression syndrome, because trigger finger involves a tendon. So all of the tendons that allow us to bend our fingers go through little tunnels. We call them pulleys. And as they go through those little, the tendons also have little sheath around them. And so sometimes when you get a little tendonitis, a little inflammation around those tendons, then they can get a little thickened. And then it's kind of like if you try to tie a knot in your belt and pull it through the loop, the tendon gets kind of stuck as it tries to go through that pulley. So people sometimes will get locking or catching. They'll feel like a snapping sensation. Sometimes the finger can get like stuck, and then you feel like you have to go like this and pop it open. That's just the tendon sheath forming a nodule and trying to get through that little loop. Often that can be fixed with either nighttime splinting or cortisone injection, or there's a little surgery similar, the carpal tunnel surgery, where you just basically release the tunnel so the tendon doesn't get stuck. The one sort of association to carpal tunnel syndrome is those tendons that get affected. They're called the flexor tendons. They do run with that nerve within the carpal tunnel. So, the nerve runs with those tendons, and then those tendons sort of branch off and go to the individual fingers and the thumb. And then the nerve, gives a branch to the thumb and then goes off to be the digital nerves of these fingers. So thoracic outlet syndrome is sort of also a little bit of a different topic that has more to do with the blood supply. And there's a little bit of controversy around thoracic outlet syndrome, and it's actually a lot more rare than any of the things that we described today. But typically we defer over to the vascular guys with the thoracic outlet syndrome. Okay, next question. Treatment for elbow and forearm pain, possibly as a result of lifting heavy objects. So we could probably, sit here for another 20 minutes and come up with, a list of different diagnoses that can cause elbow and forearm pain. And depending on what the actual individual diagnosis is, that would change the treatment for whatever the source of the elbow or forearm pain is. It can be a nerve compression. Many times when, so if I look at my patient list for the day, and depending on what the scheduler is right next to the appointment, what the complaint was, oftentimes before I even enter the room, I'll be thinking, oh, this is probably tennis elbow, just because tennis elbow is super common. It causes a range of symptoms. It does involve the elbow. It does involve the forearm. And there's, like I said, it's very common. I have it right now. It's a pain in the neck. I can relate to anybody that does have it. It's annoying. But typically that's the most common thing. But there are lots of other things that could potentially fall under that category as well. So why do the symptoms get worse at night? So that's a great question. And that is a question that can be applied to many different conditions that we treat. You know, whether a lot of times people with shoulder pain will talk about how it gets worse at night, and specifically with the carpal tunnel syndrome and the nerve compressions. One of the biggest reasons why the symptoms get worse at night is because we tend to retain a little bit of water at night, and so that anything that decreases the space that the nerve lives in, then that's going to make things worse in terms of the compression and the symptoms. So, like I said, many times just that extra fluid around the carpal tunnel. Remember, that tunnel is a defined space, and so there's only so much room that's there. And if you start taking up room that the nerve wants with things like swelling and fluid, and if the tendon sheaths swell up, if there's a cyst there, you know, anything that occupies the space that the nerve wants to live in is going to make the symptoms worse. And that just typically occurs throughout the day. So trigger finger surgery. Trigger finger surgery, again, it's sort of like, again, similar to the carpal tunnel surgery. It can be done either with some local anesthesia or a little sedation. It's a small incision, and there's different ways to do it. I like to make a little longitudinal incision right over the pulley that's involved is known as the A1 pulley. It exists sort of like right here. And so you numb up the area, you make a little incision, and then you basically just open up that tunnel. Others of those tunnels, specifically two that live here in the finger, are more necessary. Those are ones that we take great lengths to preserve. That A1 pulley that typically is the problem child in trigger finger, that one we can live without. And there are millions of people around the world that are living without their A1 pulley because they've had trigger finger releases. And like I said, it's an outpatient surgery. It can be done under local anesthesia. You know, in my protocol, I typically put stitches in the skin that stay in for about 10 to 14 days. And this goes on, this is also for carpal tunnel releases, 10 to 14 days. And I just don't like you to do a lot of heavy lifting or get it wet after the surgery. And after that, once the stitches come out, you can do anything you like.
Hi, Dr. Crivello. I know you do have some more questions, and I apologize that I have to cut you short. I do know you need to grab a bite to eat before you see your patients this afternoon. So I just want to let everyone know, thank you so much for attending the event. And if you have any additional questions, which it looks like some of you do, please just email me at programs@mbortho.com. It's on the screen right now. And I will be sure to consult with Dr. Crivello and get back to you. If you would like just to go ahead and make an appointment, you can do that online at www.mbortho.com. or call our office at 855-896-0444. Again, thank you so much, Dr. Crivello. It was great information. It sounds like people need more information about some other conditions along that they were asking about. So maybe in the future we can take a look at doing some more webinars to educate the community. Again,
Absolutely.
Thanks everyone. Have a great day, and we will see you soon.
Thank you, everybody. Appreciate it.